talk about, okay, I'm going to talk about a subspecialty of neurosurgery called rehabilitative neurosurgery. That term was really coined in the late 80s, early 90s out here at Swedish Hospital, just because there was a unique situation. It was physically connected to Craig Hospital, a model system center for rehabilitation. And a neurosurgeon in the late 80s, early 90s had access to lots of spinal cord injured patients and could start dabbling in neurosurgeries that could help with the chronic, those with chronic injuries and the sequela of spinal cord injury. And what we're talking about are issues such as progressive loss of sensory function, motor function, worsening autonomic dysreflexia, neuropathic pain, spasticity, poorly controlled. And over the last 30 years, as I've been a neurosurgeon, probably the last 25 of those I've focused essentially entirely on these issues, those with chronic spinal cord injuries. The first I'd like to talk about, or the first, and please ask questions along the way if I'm being confusing or not clear, are the progressive myelopathies related to post-traumatic tethered and cystic spinal cords. And specifically, what we're talking about, after a spinal cord injury, scarring will occur in the spinal fluid space, in the subarachnoid space, which causes tethering or adherence of the spinal cord to the surrounding dura. This can occur, this will occur from trauma, but we'll see it from spontaneous hemorrhage, from infection like just meningitis, previous surgery to the spinal cord, such as from a tumor, even chronic spinal stenosis, we'll see these. And this tethering of the spinal cord does a couple of things. It does block the normal flow of spinal fluid around the injury site, the region of tethering, and it will also place the spinal cord and rootlets on a degree of stretch or tensile injury. This can lead to progressive softening of the spinal cord, a myelomalacia, and then even cystic cavitation. And here's just an example. This, see my arrow here. Can't get it to work. This is an MRI, cervical MRI of a patient that had actually come to Craig Hospital about 4 weeks after injury. So cervical spine, of course. This is just some seroma from a surgery that was done for stabilization. This region here is the area of spinal cord injury. And about 4 weeks after the injury, you don't really see an anterior subarachnoid space or posterior subarachnoid space. The spinal cord has become scarred to the dura around it in this region. And you see a little high signal in the spinal cord on this T2 weighted image, just some myelomalacia. The patient wasn't having, was just undergoing rehabilitation at the time, no major issues. And here we are 6 months later, and you can see a progression, at least on the imaging. Worsening myelomalacia, the cord is a little fatter, and some cystic cavitation has occurred. So pathophysiologically, what's happened is the spinal cord has scarred to the canal around it. Spinal fluid, of course, made in the brain, cerebrospinal fluid, constantly being pumped around the brain and down the craniospinal axis, gets blocked a little bit from the scarring, so you get a little pressure differential off the injury site, around the injury site, and the spinal cord being scarred to the dura around it starts seeing tensile or stretch injury, and this can lead to progressive myelomalacia, cystic cavitation, and the symptoms we've talked about. Here's a patient that came to Craig Hospital about 2 months after injury when he started his rehabilitation. Again, the cervical spine here, injury site right here. And you're seeing those some pre-cystic cavitation, myelomalacia, us sending up the spinal cord, all starting because the cord got scarred. Tethered here, spinal fluid is blocked. The flow is blocked a little bit, and there's stretch injury to the cord. Now, the patient wasn't having any symptoms. He was just undergoing rehabilitation at that time. But about 10 months later, I end up getting contacted, and you can see how this just progresses to cystic cavitation. Although this looks ugly, he was only losing some sensation and a little bit of strength at the time. This to show you how the spinal cord should look and act normally. This is an intraoperative ultrasound of the spinal cord on a patient who didn't have a spinal cord injury. So the patient's lying prone, head is here, feet is down here. This is the cervical vertebra. This is the anterior dura here, posterior dura here, spinal cord, posterior spinal fluid space, anterior spinal fluid space. So in the normal state of things, you can see how the spinal cord has a pulsatile motion, moves back and forth that's about 2 millimeters of excursion. And this is synchronous with the heartbeat. And it doesn't dampen in the thoracic or lumbar spine. So its spinal cord is quite elastic in its normal state. This person just had spinal stenosis. The bone was removed in the back here. No cord injuries. This is what the spinal cord should look like in all of us. Here's a cross section or an axial section. So the vertebra is right here. Facets of the cervical spine on the sides. Lamina was here. This is the dorsal dura, the anterior dura, spinal cord. These are motor rootlets down here. Sensory will be sneaking in there. And you can see how elastic that is. The spinal cord is moving, has an excursion of about 2 millimeters there. You can see the movement of the anterior rootlets, perhaps the sensory rootlets in the back. And so that's the normal state in us in a non-injured state. If you, let's see if I can get to the next one. Okay, so here is an injured spinal cord, intraoperative ultrasound. The cervical region, head is here, feet is here. This is anterior vertebra. The lamina have been removed. This is the dorsal dura. This is anterior dura. Spinal cord is tethered or adherent or plastered to the dura in the back here, but also in the front. And you can see some cystic cavitations starting to form. So spinal fluid flow, it's being pumped down the craniospinal axis, but it is blocked a bit. And you'll see how the kinetic energy is of each pulsation is being delivered to the cord, and a little tensile injury to the cord as well. So here we are, intraoperative ultrasound, which you don't see now. This is, you see movement with the heartbeat, but you don't see that to and flow excursion. And you actually see this turbulent flow and expansion within the cyst cavity itself. And so the spinal cord is adherent here. It's lost its normal motion and excursion. So this tethering is really a very key issue that all spinal cord injured patients develop. Not all of them have issues from it, but they all develop it. And trying to get to the next slide. Oh, there we go. So what is the clinical presentation? And the presentation of these patients is identical for a tethered spinal cord or a tethered spinal cord with a syrinx. They go together. Often it's separated, post-traumatic syringomyelia versus tethering, but it's really a continuation of a process. We consider all of those together. All patients get a degree of cord tethering after an injury. You get inflammation and scarring in the spinal fluid space, usually from blood products. So they will all tether. Some, in addition, will get a syrinx, but the major issue is the tethering. And that's not always understood. And we can see anywhere from a month after injury to more than 40 years later, somebody progressively losing motor function, sensory function, develop new or worsening spasticity, new or worsening neuropathic pain, new or worsening autonomic dysreflexia, to be very high blood pressure swings or very low, abnormal sweating, hyperhidrosis, Horner syndrome, hypothermia. We've had a few patients whose core body temperature has dropped very low in the high 80s. That's unusual, but we can see that. Some will get headache, blurred vision, and cognitive impairment, which we've associated with impairment of CSF flow, and extremity edema we've seen, mostly lymphedema. The way you make a diagnosis of a progressive myelopathy related to to cord tethering or a syrinx is often one of exclusion. So you have to rule out obvious anatomic causes. Does the patient have spinal stenosis and cord compression, a degree of spinal instability? We always rule out primary neurodegenerative processes such as multiple sclerosis or motor neuron disease. Every year or two, we always diagnose one of those. And you also have to rule out complications of spinal cord injury, which can mimic a progressive myelopathy, such as somebody that has significant tone or spasticity may just be fighting their spasms. And they think perhaps that they're losing motor function, but they're just not overcoming their spasticity. So if you relieve that with baclofen or something, they get their function back. So we always rule out things like that or other nociceptive sources, noxious stimuli, such as heterotopic ossification, urinary tract infections, skin sores, bladder, kidney stones. These noxious stimuli, which can trigger spasms, autonomic dysreflexia, neuropathic pain, hyperhidrosis. And then ultimately, pulmonary hypertension, somebody that has a PE, pulmonary embolus, or pneumonia and develops during that time pulmonary hypertension can increase intraspinal pressures and temporarily make the spinal cord look worse. But if you rule all those out and they have the classic symptoms of progressive loss of sensory function, motor function, worsening spasms, autonomic dysreflexia, neuropathic pain, then it fits very much progressive myelopathy from a post-traumatic tethered spinal cord with or without a syrinx. And for neuroradiology, what do we most commonly use? It's an MRI or a CT myelogram to diagnose the tethered spinal cord or a syrinx. But it's important to note that these can rule in spinal cord tethering, but they cannot rule it out. Spinal cord tethering is often ruled out by a radiologist on an MRI, and that's a mistake. In cases of spinal cord injury, we have many patients that are ignored because they're being told there is no cord tethering. And here I'm going to give you an example. This is an MRI of a patient of mine who is an incomplete paraplegic individual. So here's the thoracic spine, lungs are here, back is here, head here, feet here. The gray tube, obviously the spinal cord, and that tiny little white dot right there was her area of spinal cord injury. So she was very incomplete. She was a long distance runner. And then she just started losing sensation in her legs, started losing strength, could no longer run, less ambulatory. And MRI just looked completely normal, except that little white dot. And neurosurgeons, which I agree, you're not going to operate on that little white dot. You're not going to put a tube in it or anything, but was told there's no issue, no cord tethering, anything else. And she's progressively losing function, loss of sensation, strength, spasms getting worse, and so forth, like we classically see with post-traumatic cord tethering. So we did take her to surgery. And here, once again, is the intraoperative ultrasound of the same thing, of that same MRI. So she's lying prone, spine here, lamina were removed here. This is dorsal dura, anterior dura, this is spinal cord. This hyperechoicity on the ultrasound is the area of contusion. And here you see a band of scarring in the back, but you'll see on ultrasound, I'm trying to capture, you don't see the, this is real time, you don't see the pulsatile motion of the cord, but here are regions of scarring in the posterior subarachnoid space and tethering all through this region here that is not picked up on an MRI. So this is just a caution that imaging studies can rule in post-traumatic cord tethering, but you cannot definitively say the cord is not tethered based on that. From my experience, if a patient has a spinal cord injury with some level of permanent neurologic deficit and any imaging studies showing evidence of the cord injury, they will have in fact scarred, they will have had an inflammatory response and have scarred in the subarachnoid space around the injury site. And next slide. So what do we do? The surgical technique is to release the scar tissue and untether the spinal cord and rootlets to restore spinal fluid flow through the regions of tethering and decrease the tensile or stretch injury to the neural elements. 80% of the time, if they have a syrinx, it just collapses when we do that and nothing further need be done. But we do determine if a shunt is additionally needed with intraoperative ultrasound if the untethering doesn't result in the syrinx collapsing. And then we expand the dura with a duroplasty to help prevent retethering. And we've done approximately 1,600 of these surgeries. I have in my career about 1,300 of them have had a syrinx, about 300 have not, with zero syrinx whatsoever. And here are some example cases. This is an MRI of an intraoperative ultrasound that I showed earlier. So this patient is quadriplegic. Here's cervical spine here, throat here, back here, head, feet. That little cystic area is at the injury site. And this patient was progressively losing sensation, strength, function, worsening spasms, and neuropathic pain. And here's the ultrasound I showed before of that patient. So he's lying prone, head here, feet here. Lamina have been removed. This is the dorsal dura, anterior dura. And just to remind you, there's no pulsatile motion of the cord. And you see how CSF flow in the heartbeat is treating this cystic area with this turbulent flow. And here, the next slide will be, get this. Now the cord has been untethered. So here's the dorsal dura. The cord has been released off of that. It has fallen forward. And just by doing that, you see how the syrinx has collapsed. But more importantly, as I make this real time, you see how we've restored the motion of the spinal cord. So this is synchronous with the heartbeat and CSF flow, caudal to it, encephalate to it. Tensile injury is a huge part of tethering, and regaining this elasticity is a very important part. Didn't have to put a shunt tube in here; it just simply collapsed on its own. And here we are on a postoperative MRI. This is about 10 days out. There's the duroplasty. We've restored spinal fluid flow. The syrinx has collapsed, and the patient regained function. Did quite well. Let's see, next slide. Here's just another example of a patient that had this high thoracic injury right here. So cervical thoracic spine, lungs here. This is base of the brain. The syrinx goes all the way up to C1, so a widely dilated syrinx. This is the area of injury in the upper thoracic spine. This is just old seroma from the patient's original stabilization surgery. And then there's a descending syrinx going down. This patient was losing sensory and motor function, actually everything, worsening spasms, neuropathic pain, autonomic dysreflexia. And we go to the next slide. Here's the patient at surgery before his spinal cord was untethered, lying prone, head here, feet here, lamina removed in the back. This is dorsal dura, anterior dura. This is the spinal, this is the injury site. Here's the syrinx ascending up toward the brain. Here's the descending part. And if we just look at it real time under ultrasound, you can see quite the dynamic movement of the cyst fluid within the cord, but there's no flow of spinal fluid dorsal, and the neural elements are all being quite stretched with this dynamic flow. And here, this is the duroplasty. So the dura has already been opened, the spinal cord released of the scar where it was scarred all around to the dura. You can see how regions, just by releasing the scar, the cysts collapse on their own. But if we go real time, you can see now how the spinal cord is moving again. syrinx is collapsed. This is injury site, but as we travel throughout all this area, it's regained its motion again. So elasticity and flow are huge, huge issues with this. No shunt tube needed, so the syrinxes have collapsed just with release of the tether of the neural elements to the dura around them. We go to, and here we are post-operatively. So although the syrinx went all the way up to the C1 level and down, we operated only at the injury site to release the spinal cord off of its traction, restore CSF flow and motion, and then classically cystic cavitation resolves in both cephalad and caudal directions. That skinny little line there is the descending cord with the syrinx collapsed. This is an MRI I showed before of that patient that initially had this pre-cystic cavitation that ultimately went up to the brainstem. We just, again, it's not uncommon for people to think you need to enter a syrinx, more cephalad, put a tube in, but you don't. We just operated right at the injury site to release the scar tissue and restore the flow of spinal fluid. And here you see post-operatively, here's the duroplasty right here. Spinal fluid flow has been restored, motion of the cord, and then the syrinx. The syrinx fluid just egresses out of the cord into the spinal fluid space. Here's one last one. This is not a very good MRI, but every once in a while we do have to put a shunt tube in. Here's lower thoracic spine. This is the region of the conus. And here's a cyst cavity within the conus. This person was losing extremity function and valve bladder function. And here we are. This is the injury site. Patient's lying prone, head here, feet here. Lamina have been removed. This is dorsal dura, anterior dura. Here's spinal cord with the syrinx in it. You can see it's regions of scarring. Here's some bands of scarring and the dynamic motion of the syrinx and so forth. Here, we've dorsal dura, the spinal cord has been released off of its tether. You do see kind of a collapse of the cord onto the anterior subarachnoid space. But what hasn't happened here is, in this case, the syrinx hasn't fully collapsed. It's still dilated. And although we have gained a little cord motion, we need to collapse that syrinx. So every once in a while, we have to put a tube in there. And this is a picture of the spinal cord at surgery. This is the dura that has been retracted. This is the dorsal aspect of the spinal cord. Here are dorsal rootlets coming in. And this little tiny tube that's been threaded into the midline of the cord to split the posterior columns has been placed to drain the syrinx. So here you see, after we've done that, it's starting to collapse. And so sometimes we do have to add a tube. Now you're seeing more pulsatile motion of the cord, and the syrinx has collapsed. And yeah, if I guess we look up and down we've gained a little more motion of the cord by draining that fluid. So every once in a while, we do have to add a shunt tube, and we determine that at surgery.
Dr.
And that's just
Falci, can I ask
yes.
a quick question here? So
yes.
a patient who currently has a shunt, then if you're able to, with this type of procedure, then potentially eliminate the need for shunt ongoing, is that correct?
Yes, we get lots of patients. It's rare for me these days to get the patient the first time around. We'll have patients that have had 6 surgeries or more where shunt tubes are placed up and down the spinal cord. They're often scarred in at that point. But what hasn't been addressed initially is the scarring and the tethering with an expansion duroplasty. It's usually the dura is just primarily opened and then closed in a shunt tube placed. It's probably the most common thing that we see. And that doesn't, at best, you might get a couple of months out of it, and then they rescar, retether. So yes, if we can remove the shunt tube and it comes out easily, we do, but often it's just scarred into the spinal cord itself. And even if it's plugged up or irrelevant, it doesn't matter. We can just trim it to the peel surface of the cord and just untether it and solve the problem.
Very good. Thank you.
Sure. And every once in a while, we run into a case like this, where here the person had an injury at the conus, and you just see a large expansile syrinx going all the way up the cord, just a big sack of water. And we can get away to make the surgery very quick. It all depends on the protoplasm of the patient. We don't want to put them through a long surgery. In a case where it's an enormous syrinx and the syrinx is a huge part of their issue, as much as the tethering itself, we can just thread a shunt tube from the injury site through most of the length of the syrinx. We place multiple holes through the tube. It's a tiny little tube, inner diameter less than a millimeter, but like a French drain. You just have a tube floating in there with multiple holes. And we shunt it out of the craniospinal axis into the peritoneum classically. We don't like the lung, the pleural space, just because of the negative pressures, and you can have a little too much suction with that. Learned that early in my career. I gave somebody a cranial nerve palsy, successfully collapsed the syrinx, but gave him a cranial nerve palsy with it and corrected it by putting it into the peritoneum. But that's just my personal preference. But here, a shunt tube was placed along the length of this, and you can see how it could just collapse the whole thing down. We don't commonly do that. Every once in a while, you can get a little over drainage. You can actually drain, you can get a transmile flow of CSF into the syrinx and drain some CSF, and you can get low pressure headaches, intracranial hypotension. But sometimes we can just do something as simple as that. That's rare, but just mentioning it. Other things that we run into a lot, I don't know if you all might run into it, but syrinxes that are of not a non-post-traumatic etiology, and they're not Chiari, they just kind of show up and nobody really knows what to do with them. And we get lots of these as well. Here's an example of, this was a teenage girl, 17, high school girl. She was a track star, then started getting chest pain, hands are getting a little weak and legs were getting weak, couldn't run anymore. And lo and behold, there's a syrinx here, no Chiari malformation, no tumor, no trauma, but she was told this is kind of irrelevant, no cord tethering, nothing, and nothing to do, and the syrinx was irrelevant. Well, we've learned that when we see things like this, even if we call them idiopathic or whatever, there's commonly a pathology around it. And here's a CT myelogram, which had a normal appearance, and was told there's no cord tethering or anything. But in our experience, there usually is. And she had the classic symptoms: loss of sensation, strength, increased tone, sweating, pain, and so forth, but no trauma or any other etiology. And we took her to surgery. And here's the intraoperative ultrasound again. The vertebra here, head here, feet here, lamina have been removed, dorsal dura, spinal cord. Here's the syrinx, dorsal aspect of the cord, anterior aspect. But you can see all this marked, this is just fine arachnoid webbing, but scarring through this space. And here's a cross section, scarring through all of that. So when we see these syrinxes, we're very suspicious of tethering being the etiology. And here's, we've released the scar, the duroplasty place. The syrinx has, in her case, collapsed in front of us there, before our eyes. And here's post-operative MRI. So a long duroplasty here through these long regions of tethering, but you can see the syrinx has collapsed, and she did quite well. Here's one, not uncommon that we see this. Here you can barely see the syrinx, just this little white streak. This is another young person here, just this very little white streak, same symptoms. And thoracic region pain, hand weakness, some leg weakness. neuropathic pains, and again, being told nothing can be done. And I agree, nobody would operate on a tiny little white streak. You wouldn't enter a spinal cord. But we commonly associate that with cord tethering. And here again, we took this patient to surgery. Anterior spine, lying prone, head here, feet here. Anterior dura here. Here's cord with the syrinx. There's the syrinx right there. And you can see this extensive arachnoidal webbing in the dorsal subarachnoid space. There's dorsal dura. And here's the duroplasty. We removed the scar. Syrinx didn't fully collapse before our eyes. There it is, but started gaining an anterior space here as the cord started pulling away from the thoracic spine. And here's just the duroplasty and restoration of spinal fluid flow. This person also regained function. So I guess the points I'm just trying to make is that the spinal cord tethering is something that isn't as recognized that needs to be, particularly in those with post-traumatic injury, spinal cord injuries. All spinal cord injuries, in our experience, that result in some level of permanent neurologic deficit, even in the very incomplete patients. And where you see some evidence on an MRI that there was a cord contusion, they will in fact be tethered, regardless of what the MRI suggests or a CT myelogram. You will in fact get an inflammatory response in the spinal fluid space, usually from blood products and pro-inflammatory cytokines. You will get this webbing and scarring, and can cause the symptoms we talked about. In surgery, with untethering and expansion duroplasty, is really a very successful strategy for arresting a progressive myelopathy related to spinal cord tethering and syringomyelia. Our results, we've published on them a series of 400 something that we followed for 12 years, and so I can give some data. We're successful in arresting a progressive myelopathy, so just stopping it in its tracks in 90% of patients. And we will see sensory motor return, functional return overall in about 50% of those patients. Others, it was just permanent loss of function. We do these surgeries as well for issues of just severe neuropathic pain, refractory to everything else, progressive, particularly if it's a late onset of pain that wasn't there in the beginning and is new, or was there early on after injury and has markedly worsened. In about half of those patients, we will see an excellent reduction in pain, half really no change at all. So we do spinal cord untethering surgeries for simply pain, and that's usually for patients where it's just 9 and 10 out of 10 pains and they're almost bedridden and it's very, very severe. We also do it for severe cases of autonomic dysreflexia and spasticity, where these cannot be controlled pharmacologically. That's not uncommon for us, actually, to have patients that are showing up in the emergency room weekly to control their blood pressure, and just pharmacologically, it has not been able to be controlled. And the same with spasticity, just severe spasticity, even with a baclofen pump. And in those, we will, and cases, we've even had a few cases of poorly controlled hyperhidrosis that has led to skin sores. And in those, we're about 65 to 70% successful of substantially improving their conditions. So we predominantly do these for sensory motor loss of function, and secondarily, cases of very poorly controlled autonomic dysreflexia, spasticity, and hyperhidrosis. So those are our most common reasons. I just will note that about 17% of our patients, after we untether them for progressive loss of function, actually gain function that they never had any time after their injury, as if we regenerated their spinal cord to some degree. And of course, all we've probably really done is that we've allowed neuronal recovery of function that never occurred in the post-traumatic period, in the recovery period, just because some population of the neurons were placed on stretch by tethering and couldn't fully recover. Their saltatory conduction, electrical conduction, just was not allowed to occur until we took it off of its traction. And a patient's perception of surgery to fail arresting progressive myelopathy really corresponds closely with retethering or rescarring. And that overall is about 10% of our patients clinically will retether, rescar in about 10 years, 90% don't. So we have a pretty reasonable track record when we do that. There's another, if there were no questions on that, there's another area that we get into for severe neuropathic pain. And this, unfortunately, is only limited to the paraplegic population and HCA, so the complete injuries. And this is surgery to the dorsal root entry zone for neuropathic pain. And so these will be classically patients that have the sharp, burning, stabbing, electrical pins and needles pains. Since they're paraplegic, it's generally in the lower extremities, but it can be in the genitalia region, gluteal, rectal regions as well. And usually the pain is refractory to everything. They're on high doses of opioids. They've been on Lyrica, Neurontin, the antidepressant medications. They have intrathecal opioid pumps. They've tried spinal cord stimulators, and basically, by the time they get to me, they're bedridden, and life's pretty bad. So here's just a cartoon picture of a cross section of a spinal cord. So this is the gray matter here, sensory rootlets coming in to the dorsal root entry zone, so the posterior gray matter. And when we're talking about this, we're talking mostly Rexet lamina 1, 2, 3, where the predominance of the pain fibers synapse with the second order neurons. When we expose the spinal cord dorsally here and expose the dorsal root entry zones, we explore regions cephalad to the injury and caudal to the injury, because regions caudal to the injury are relevant as well. And we place electrodes in here during surgery real time, and we can record real time with just computer subroutines. And here's an example of just a normal, quiet recording in the dorsal root entry zone, about 2 millimeters in there, in the regions of the substantia gelatinosa, Rexet layers 1, 2, 3, and you just get this low energy, low frequency activity. This little spike here is just an EKG artifact. That's the heartbeat. And here's just a depiction of what we do. We place electrodes up and down the dorsal root entry zone, above the injury site, below the injury site, and we will find two kinds of recordings, and we just call it cold or hot. In the normal areas, you'll just see this very low frequency, low energy activity, or very high frequency, high energy activity that very much looks like seizure activity. And this is under a general anesthetic now, and patients getting opioid and everything. And these regions are firing spontaneously, unrelated to any external evoked response. So what we find in these patients are basically epilepsy of the spinal cord in the posterior gray matter. So these regions are just firing spontaneously. And when we ablate, we then locate all these areas and ablate them, and 85% of the time, we completely knock out the sharps, the burns, the stabs, electrical pins and needles, where it's basically just turned off. They say that they don't feel those anymore. 15% of the time, we completely miss, and they still have the pain. Interestingly, there's a novel somatotopic map to where we find this activity, and it corresponds very closely with the intermediolateral cell column innervation of the body. So the motor, the efferent sympathetic system. So wherever that end organ innervation is in relation to this activity, to the sweat glands and the blood vessels and so forth of that part of the body, that's where they will in fact perceive the pain. And we've learned that this very much is a sympathetically mediated pain. Particularly, we've published on a small series of patients that we operated only caudal to their level of injury, and they had transected spinal cord. So we operated caudal to a transected spinal cord and got rid of their pain, suggesting that this activity must have routed around the sympathetic chain to get that response. So we do DREZ surgery. What are the positives? 85% of the time we get complete relief of the neuropathic pain, and generally they do wean off of their pain medications. But we do lose sensation in all regions we do this. So their sensory level will ascend to regions where we find this hyperactivity. And 15% of the time, heat will be transferred to the motor column, so we could lose motor function. So we will not do this in incomplete patients just because we feel the risk is too high to them functionally. But for the HCA patients that already have a neurogenic bowel and bladder, we do offer this, and it really can be life-changing for that segment. This surgery and research we have done to these regions of, I go back here, we have had IRB approval for many years now to sample or biopsy these areas of hyperactivity in regions we're going to destroy anyway. And we have analyzed it with proteomics at the moment. They've looked at 5,000 different cellular proteins, soon to look at 11,000, basically in these regions. And what we have done, and this is just a volcano plot, and it's basically each dot represents one of the 5,000 proteins. And it's probably a bit of a confusing picture here, but this red box represents those proteins that have a twofold or more increase and abundance of that protein in the electrically hyperactive tissue versus the normal tissue are represented here. And anything above this line represents a false discovery rate or significance less than 0.05. So here's an example of about 90 of these proteins that were markedly upregulated or increased in abundance in the hyperactive tissue versus non-hyperactive tissue. And we are using these as potential new drug targets, not only for repurpose of drugs, but for development of new drugs. I just labeled one here, SV2A, as synaptic vesicle 2A protein that we found, and mention it just because the drug brivaracetam, Briviact, which was the next generation after Keppra, just had a much higher affinity to SV2A than Keppra did. Because we found this, we put that through a clinical trial, and see if I discussed that at all. Yeah, we just completed our first FDA-approved clinical trial, just looking for new drugs already on the market, just to repurpose that could help with this neuropathic pain. And our early results are showing about a 2-point decrease in pain in patients who have failed all other medications, Lyrica, Neurontin, opioids, and so forth. And we have an additional trial planned this year to a different target for drug repurpose we hope might be effective. So we have things going on with the hope of being able to treat neuropathic pain with other drugs that are not currently available. We do treat spinal spasticity is a common thing that we treat as well, that everybody's familiar with, the intrathecal baclofen pump. But we do run into some patients who just do not want anything implanted for any reason. They're just against that. So we do offer selective sensory micro-rootlet sections. And basically, here's just a picture of the dorsal aspect of the spinal cord. This probe is showing sensory rootlets coming into the cord, and we can just cut a portion of them, selectively transect a portion of these sensory rootlets in patients who do not want a pump, and specifically those rootlets that go to that part of the body and dermatome that's having the spasticity. What the positives for that is it's very effective for those patients that don't want to pump. The negative is once we've done that, they can't get their spasticity back. If they want to have some level of tone, as some patients do with the pump, where they can adjust that, you can't do it with this. It's a permanent change once we've done that. But that is another thing we offer. And then another thing we run into a lot are the spinal instability, the Charcot-spinal instability. And this is just to briefly show that these the spinal cord injury patients can see marked bony deterioration. Here you just see lots of loss of vertebra and disc, and sometimes it's two segments we'll see it just kind of melt away over time. And that can create obvious issues of just posture, skin sores, if they start hinging at that area, compromise of the abdominal contents. It can cause stretch injury to the spinal cord, issues of spasticity, pain, so forth. And so we do deal with this, in combination with an orthopedic spine surgeon, treat these as well. So this is kind of a good synopsis of our program and the things that we treat, and I'm happy to address any questions.
Thank you so much, Dr. Falci. Yeah, feel free to unmute and ask questions, or if you're not at a place to do that, put them in the chat and I'm happy to read them off. Dr. Falci, I think one thing that stood out to me early on in your presentation, you talked about how a lot of symptoms may not even start to present or worsen until sometimes, was it up to 40 years post-injury?
Yeah, yes, we've had, yes, that's correct.
So even patients who have had, as you had mentioned, numerous surgeries and, you know, have gone through rehab, physical therapy, things like other treatments, can still be helped by these types of approaches, correct?
Oh, yes. If it's related, yes. If clearly their progression of symptoms fits cord tethering with or without a syrinx, then absolutely.
No, that's exciting.
Yeah, regardless of the number of surgeries that they've had.
Absolutely. I don't see any questions in the chat. Any questions that people want to ask live? If not, greatly appreciate your time and you know, for joining. Dr. Falci, thank you so much for taking the time to just share insights into these types of procedures. And hopefully everyone found this helpful and useful, and potentially even patients that you see right now, you're thinking of how they could even be further treated and helped. So with that, thank you. Hope everyone has a great weekend. Appreciate your time, and we'll let you get back to your day.
Thank you.